We'll start by reviewing insulin terminology. The term basal refers to long-acting insulin coverage. These insulins include Lantus and Levemir. Long-acting insulins do not peak and have a duration of up to 24 hours. The term bolus refers to fast-acting insulin. These insulins include Humalog and Novolog. These are used for both correction dosing, known as ISF or sliding scale, and carb coverage insulin, also known as ICR. Fast-acting insulin begins to work within 5 to 10 minutes of administration and peaks in 30 to 90 minutes, with a duration of up to 4 hours. We will now be following Bob throughout 2 days of his hospitalization to help his nurse optimize his insulin management. Bob is a 68-year-old male who is being admitted to an acute adult unit for heart failure exacerbation. Bob has a history of type 2 diabetes mellitus with an A1C of 9.5. He is compliant with his prescribed diabetes management at home, which consists of long-acting insulin and metformin. While hospitalized, his metformin will be held and he will be started on sliding scale and carb coverage insulin in addition to his long-acting insulin. It is now 09:45 and Bob's breakfast has just arrived. His blood sugar is obtained prior to his meal and it is 2:43. He eats all his breakfast, which contained 54 carbs. It is now 11:15 and to our surprise, Bob's lunch has now arrived. The patient care tech obtains his blood sugar before he begins to eat and it is now 3:02. He eats his entire meal and the meal ticket reveals that he has had 35 carbs plus a chocolate ensure containing 32 additional carbs for a total of 67 carbs. You are reviewing his MAR and note that his breakfast time sliding scale and carb coverage insulin were given at 10:08. Because Bob had his breakfast and lunchtime meals so close together, we have to consider the possibility of insulin stacking. If Bob would have received both sliding scale and carb coverage at both mealtimes, insulin stacking would have occurred. Insulin stacking occurs when a dose of sliding scale insulin is given less than 4 hours from a previous bolus insulin dose. So that can be either sliding scale or carb coverage. Sliding scale or correction insulin treats high blood glucose, and if that blood glucose is tested before 4 hours has elapsed from the previous dose, insulin stacking can occur because too much insulin will be on board. As long as Bob is not hypoglycemic, carb coverage can always be given as it allows him to burn the carbs he has just consumed. It is now the next day, and you are taking over care for Bob at 1500. You are completing bedside report at 15:30 when you notice that Bob isn't quite himself. He is very drowsy, diaphoretic, and confused as compared to yesterday. You quickly obtain a blood sugar, and it is 54. Bob is alert enough to drink, so you correct his blood sugar per the hypoglycemia protocol. At his 1-hour recheck at 16:45, his blood sugar is now 104. Bob orders dinner, and it arrives at 17:30. His blood sugar is currently 112, and he consumes 65 carbs. You review Bob's MAR after his hypoglycemia episode and understand that it was likely caused by insulin stacking earlier in the day. You notified the provider of the event and discussed the evening insulin dosing. It is decided that you will give the carb coverage for his evening meal. You give his carb coverage insulin at 1800. His blood sugar at 2100 is 165. Bob's blood sugar was obtained within 4 hours of receiving his dinner time carb coverage insulin dose. He should not receive sliding scale at this time to help prevent insulin stacking. Ideally, his blood sugar would be obtained at 2200 or later to assess his need for bedtime insulin. You want to ensure that there is 4 hours between the time of the last bolus dose of insulin and the next blood sugar being obtained. Note that Bob's long-acting insulin is also ordered at 2200. Basal or long-acting insulin cannot be held without a provider order. Do not hold if a patient is NPO or hypoglycemic without notifying the provider and obtaining an order. Now we will review insulin pumps. Insulin pumps administer bolus or short-acting insulin continuously to provide basal coverage with intermittent bolus doses for carb coverage and correction. Some insulin pumps can be paired with a sensor to automatically adjust insulin or suspend it to treat hyperglycemia and prevent hypoglycemia. These are known as automated hybrid closed-loop insulin delivery systems. Patients need orders to use their insulin pumps in the hospital setting. These will appear as medication orders and will be ordered in the MAR. Patients must have the ability to use their own pump as we cannot operate it for them. It's important that they are alert-oriented and able to operate their pump. The nursing responsibilities related to insulin pumps include that patients must sign a consent to use the pump while inpatient. These can be found on your units, or if they're not available on your units, they are available on the X drive in the shared folder under patient care record forms. Nurses must document bolus amounts and times when a patient has administered their bolus. The barcodes to scan them come from pharmacy and will be delivered from the pharmacy, typically via the tube station. You must document insulin pump infusion sites in the LDA avatar. For example, if there was any redness, drainage, swelling, anything occurring at the site of their insulin pump. Ensure that all patients using their own pumps have an inpatient consult to diabetes educator, and this order can be initiated by the nurse. Now we will review continuous glucose monitors, or CGMs, which are commonly referred to by their brand names of Dexcom or Freestyle Libre. CGMs only measure glucose levels. They do not administer insulin. CGMs measure the glucose level in the interstitial fluid. Blood glucose and interstitial fluid glucose fluctuations occur at different rates, meaning that CGM and blood glucose readings are rarely ever the same at the same time. This does not mean that the results of the CGM are inaccurate. CGM results lag behind POCT glucose readings by about 10 to 20 minutes. If ordered to use CGM, it is not necessary to compare to POCT glucose levels unless the patient condition warrants additional testing. If you suspect that the patient may be hypo or hyperglycemic, which is not indicated by their CGM, that would be a good reason to obtain a POCT glucose. CGM results must be documented in the glycemic management flow sheet at the interval ordered. If it's ordered for ACHS, we would document an ACHS in the flow sheet as pictured here on the right-hand side. We will review diabetes education. It is the responsibility of the primary nurses to complete education with diabetic patients. All new diabetics and those with an A1C greater than 8 should receive a diabetes smart folder. Reach out to your leadership team if you're unsure where your smart folders are located on your unit. If your unit runs out, more smart folders can be obtained from the nursing services office. Utilize the smart folder checklist to ensure that all education is being done, and turn the checklist into the designated person on your unit's leadership team.